Oh, Nat, we can't hear you.
Can everyone hear me now?
Yes, we can. Perfect.
Okay, excellent. Okay, I'll start that again. Welcome everyone to the A.I.M.S. pharmacological and non-pharmacological approaches to hyperglycemia. We have with us tonight Associate Professor Margaret McGill. Margaret is an Associate Professor with the University of Sydney's Central Clinical School, Faculty of Medicine and Health, and Associate Director of the Royal Prince Alfred Hospital Diabetes Centre. Marg has a very broad range of experience in developing innovative clinical services for diabetes and medical and health professional education, and is recognised as a global leader in these areas. She was named in the 2011 Australia Day Honours List with the award of Order of Australia for her contribution to diabetes nationally and overseas. Okay, so I'd just like to do an acknowledgement of country. I'm in Broken Hill, the land of the Wuli people. We acknowledge the people of the Baikinji Nation and the different nations on which the people here sit today. We would like to acknowledge that we work on the traditional lands of many Aboriginal clans and nations, and I pay respect to elders past, present and emerging, and acknowledge their continuing connection to land, water and culture, and for their contribution to help shape the life of the communities in which we all work and live. We recognise that sovereignty has never been ceded and are committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social well-being. We welcome Aboriginal and Torres Strait Islander Australians who are present in this meeting. And I'd just like to also say that this event tonight has also been partnered with Marama, and Marg and Professor Stephen Twigg visit Marama regularly throughout the year and do trips out to our regional remote centres to do diabetes management out there. Some housekeeping. This webinar is being recorded and will be available on our website within a couple of days. Everybody has been placed on mute to optimise sound. For questions, we have the question discussion panel. Please type them in there. Otherwise, you can use the chat box to enter questions as well. And we'll just show you here that that's where the question box is. The control panel for the webinar tonight is under this little orange arrow. You'll see the different functions available there. So if you need to check anything or put your questions in or have it in the chat, then please make sure that you use that little orange arrow to get you there. Without wasting any more of your time, I'd like to pass you over now to Margaret McGill, who will start the presentation.
Sorry, oh dear, every time I mute it goes. I'm really sorry. Can you hear me?
Yes, we can hear you.
Yeah, every time I click one of the buttons, it goes onto mute. So I'm very sorry about that little delay. And I'd really like to thank Natalie and PHN and Marima for asking me to speak to you tonight on this topic. It's titled A.I.M.S, the pharmacological and non-pharmacological approaches to hyperglycemia. Now, we've all had the experience, we're all here tonight because we're interested in diabetes. We've all had the experience of a person coming to see us, we open up the pathology and the hemoglobin A1C is 10.5%. and our hearts sink. We think, oh my goodness, what are we going to do? But I'd like to say to you that the first thing we don't really want you to do is just increase the medication, because there may be many other reasons why the person has high blood glucose levels. So what you've got to think about is, what are the different things that we need to think about when that person is sitting in front of us tomorrow morning in our clinic, and they've got this A1C of 10%, what can we do to make it better without necessarily increasing the medications? And so Professor Stephen Twigg and I came up with this acronym A.I.M.S, and it's to help you think about the causes of hyperglycemia. And this is something that we teach all our junior doctors and our nurses at the Diabetes Centre at Royal Prince Alfred, that if a person comes in and their blood glucose levels are high, their A1C is high, what is it? Look, it may well be that they're under-medicated, but it may be a whole lot of other reasons. And the A stands for adherence. Have they been adherent to food, exercise, diabetes medicines and other medicines, and attendance? I stands for infection or inflammation. The M stands for medications other than their diabetes medications. And the S stands for something else or secondary causes. So this is what we really want you to go through in your mind as you see that person with high blood glucose levels. So let's think about adherence, and first of all to food. And really the big problem with food is our portion sizes are often way too big. One of the things we have to be careful about though is that we don't over-treat people. And if you just keep putting up the insulin doses or the diamicron MR doses that lead to hypoglycemia, what this can do is lead to overeating. And if you are measuring somebody's weight and you can see that they are gradually increasing in their weight, it may be a red flag that we're over-treating them. Now, conversely, overeating can lead to over-treatment. And so again, we get into that vicious cycle, and both of them will lead to high blood glucose levels and weight gain. So what can we do about it? Well, we can do some very practical things. We don't have to always send somebody to the dietitian, but as GPs and nurses and Aboriginal health professionals, there's lots of things that we can do. Get some food models and bowls and plates and have them in your office, cartons, to talk to people about how much they're eating and how much they serve. One of our dietitians cooks up rice and pasta, and in our group of patients for type 2 education, she asks them to serve themselves a typical bowl of rice or pasta that they would have. And often it's a huge amount, and there's almost no medication apart from short-acting insulin or rapid-acting insulin that could cope with that amount of carbohydrate. So it's really important that we do show people what a regular serving size or a reasonable serving size would look like. And I have to say, many people are really surprised at how much we should be eating. And one of the things that we do, if people can afford it, is to suggest that they might go onto one of those eating programs like Light and Easy, where they get more practical information about what a typical serving size should be. And most of them are really horrified by how little there seems to be on their plate. And again, another big, you don't need to have fancy scales or anything too complicated. Another practical approach is to say to the person, you shouldn't have a carbohydrate serving size larger than the size of your fist. So for example, the rice, the pasta, the potatoes, there shouldn't be bigger portion than your fist. So if you're a big man, you've got a big fist, you'll have more carbohydrate. If you're a smaller person, you'll have less. The other very practical thing, and we often forget about foods that have hidden sugars. And I, for one, love coffee milk. And I looked at it the other day, I looked on the bottle to see how much sugar was in there. And I was horrified at how much there is. And I know that a lot of people out in the Broken Hill area also, like me, love coffee milk. And it's a very quick way of putting blood glucose levels up and out of control. So now let's move to continue with the A theme of adherence and think about exercise. So if somebody comes to you and their blood glucose levels and their A1C have drifted up, it's an important question to ask them, has your physical activity changed of late? And they might say, oh yes, my knee's been sore, I haven't been walking. Because we know that regular exercise can improve the A1C by 0.5%. And so consequently, stopping exercise worsens blood glucose levels. And all of us have been affected by COVID. And there is no doubt that many of us are like this puppy dog, where we've been sitting on the lounge, we haven't been doing much exercise, we've been accessing the fridge, and we've put on a few kilos. So this has certainly had an impact. And I would say that probably the majority of people that I've seen in recent times have put on some COVID weight. The other thing that we've got to cope with, and particularly this weekend and the next few days, but also over the summer in the far west, is the hot weather. I know people can access the gyms that are air conditioned or go to the pool as long as it's not being renovated. But hot weather, it's very unappealing to do exercise in hot weather. So that can be another reason. And then we can just talk to the person about perhaps other things that they could do in the aircon of their home, because many of the houses do have aircon, I know. So how can we improve the exercise levels for people? Well, there's no point in us as health professionals saying to somebody, oh, you've got to exercise. The recommendations are that you have to do 150 minutes a week and then you've got to do some strengthening exercise. A lot of people can't do that. So they need to find something that's fun. It might be dancing, it might be boxing, it might be walking with a friend. But again, the expectation is that the person, a lot of people are very unfit and aerobically very unfit. And so just start with a few minutes a day or a few minutes a few times a day and gradually build it up. And along the way, we have to praise people, not criticize them if they're not keeping up their exercise. So we've got to encourage people so that they want to keep walking. And there's no doubt that all the technology toys now that people have with watches and phones and things that can count steps is a good way of trying to keep your steps up. It is sometimes horrifying, and I know with COVID, with people often working from home, sitting at home, they end up with only doing a few hundred steps a day. So try and get people out and exercising as much as possible, because we know that that will improve their A1C. Continuing on the A adherence theme, adherence to diabetes medications is a major issue because we know many people find it very difficult. Lots of them are on polypharmacy and they find it very difficult to stick to taking the medications as required. And this is just an example of a man, a patient of ours who was 65 years old. He lived alone. He had 10 years of diabetes with multiple comorbidities. His A1C was 11%. He was on metformin maximum, glycoside maximum, and sitagliptin maximum. And with an A1C of 11%, he needed to start insulin therapy. And the nurse went to the house to help him start this new therapy. And this is what she found. You can see he had a blister pack with all his tablets in it, and he would take them out of the blister pack and put them in this plastic bag, along with all the other precious things of his life, like his false teeth. So this person didn't need to start insulin. We just needed to talk to him in a practical way and together decide how we could best get him to take his medications. And if, for example, like some people, they will say to you, look, I really don't want to swallow all those tablets. I'd prefer to be on insulin. Then maybe that's the solution. So think about adherence, because we know, for example, at RPA, patients with diabetes are on at least 7 tablets a day. And we know from studies all around the world that up to 50% of people with diabetes do not take the medicines as you have prescribed them. So it's really important. This is again what we teach our nurses and our junior doctors at RPA. It's really important of the history taking to find out if the person is taking their medications as you've prescribed them before you change the dose or the medication type. So if somebody's only taking their insulin 50% of the time, well, what's the point of increasing the dose? What we've got to do is try and get strategies so that people will take it as required. So it has to be practical. Somebody might say, well, yes, the doctor's prescribed my Lantus or my optician insulin before I go to bed, but I'm often so tired I forget to do it or I can't be bothered doing it. Talk to the person, change it to the morning. It won't make that much difference. And so we've got to work out ways of making things simple. For example, TDS medications, most people, or TDS injections, most people forget the lunchtime one. So try and organise it so that it's very practical and people can do things in a simple way. Because if you just keep increasing the doses, what's going to happen is if a person takes a big dose of sulfonylurea or an insulin, big dose of insulin, it'll lead to severe hypoglycemia. And so then what happens is either there can be increased morbidity from angina or even heart attack, or what happens then is that people sometimes take the insulin, it causes hypos, so they stop. Then they take it again because their sugars are high, and then they stop. And so then what happens is you have these swinging blood sugars of mountains and lows, and they feel terrible when their blood glucose levels are swinging so much. So part of the history taking is sort of almost to assume that people miss their tablets or injections. And you ask the question in a non-judgmental way, but sort of giving them permission to say to you, oh yes, I take it about 30% of the time or 50% of the time. So just remember, adherence or non-adherence to medications is a very major cause of elevated blood glucose levels, and simply increasing the dose of what you think they're taking is not the answer. What is the answer? We've got to try and help people, and I know the Webster packs are extremely well used in the Far West and very well looked after by the pharmacists there, and it's fantastic. More tech things are, there are apps now for people to help remind them to take their medications. Continuing along, still on the A adherence, non-attendance of appointments. And we all have people who don't like to attend, but we do know that the non-attenders have poorer outcomes than those who attend. And people come up with lots of reasons, and it's often work. But also people will say to you, will say to me, well, I didn't come and see you because I knew my blood glucose levels were out of control and I was embarrassed and I didn't want you to know that things were so bad. And the answer is, this is the very time I want to see you. We need to see you so that we can help you. When things are going well, we don't need to see you. So it is really important, if you think your blood glucoses are out of control, to come back and see us so that we can help motivate you again in your self-management, so that we can discuss things together and make shared decisions about what you think would work for you. Adherence. So we've got to think of our aging population. What's the most common risk factor for type 2 diabetes? It's age. People are living longer. More people are developing diabetes. More older people are developing diabetes. And so you've got to have a think about, well, is this non-adherence problem because the person's developing dementia and losing their self-care skills? We know that people who experience severe hypos have an increased risk of developing dementia. It's a bidirectional relationship, and those with dementia have a greater risk of hypos. So in this bidirectional relationship, have a think about, is this person's self-care skills going off because they are dementing? So what are some of the strategies to improve attendance? As I said, it's important that as health professionals, we don't criticise or judge people and rouse on them. I know that there are health professionals who do that because my patients tell me. And our communication skills are absolutely essential. This is not about what we want in the consultation. This is what the person with diabetes wants. We have to help them. We're there to guide and help them and share decisions with them and work out what they think that they can do. And if we set goals together, it's often much more beneficial. Okay, so let's leave A and move on to I, which is inflammation and infection. And we know that inflammation causes insulin resistance and worsening of beta cell deficiency. And elevated blood glucose levels increase with infection. Now, we all know about the common causes of infection and inflammation, but there are some overt infections that we often don't think about, such as, for example, a urinary tract infection in the elderly. But an infection like pneumonia, if you're sick, you know that your blood glucose levels will go up. However, there are lots of subtle infections, and increasingly the diabetes world is recognising the role that periodontitis, or inflammation of the gums and receding of the gums around the teeth as shown in this photo, is a very common cause of high blood glucose levels in people with diabetes. So again, as part of your history, it's a very important thing to ask the person about their dental health, to have a look at their teeth, and where possible, refer them to a dentist who can help with the periodontitis. Interestingly, it's not necessarily antibiotics they require, but it's teeth cleaning and other strategies. So very important to think about periodontitis as a cause of the blood glucose and the hemoglobin A1C rising. And then, of course, there are inflammatory diseases like arthritis, rheumatoid arthritis, polymyalgia rheumatica that we need to think about as well that may cause high blood glucose levels. So the overt infections, obviously it's quite easy to pick up. But as I said, the subtle infections are much harder. And we now recognise that with the gum disease or periodontitis, about 75% of people in a UK study with type 2 diabetes had bleeding gums. And that's a sign of periodontitis. And just simply by treating the gums, you can improve the A1C. As I mentioned before, urinary tract infections in older people, as you all know, are often very subtle and asymptomatic. So again, if a person has a high blood glucose level, which is sort of unexpected, or a high A1C, think about whether they have a urinary tract infection. Because we know that older people can sort of go off with their urinary tract infections. It can lead to incontinence. They're trying to get up in the middle of the night and they fall over. So we know that the treatment of those infections will improve blood glucose levels and their quality of life. On the other hand, elevated blood glucose levels may be a warning that a virus is coming. Now let's move to medications. So some practical solutions here are just, has the medicine passed its expiry date? Well and truly passed its expiry date. Or if this is not medicines, but people often hang on to their blood glucose testing strips and they're way past their expiry date. The other thing that's important to recognise is, does the insulin that you are using match the glucose profile? And this is typical of, for example, steroids. The pattern with steroids is that the blood glucose levels will rise quite steeply in the middle of the day and into the afternoon and evening, and then drop off during the night. So something like Toujeo, if you're on steroids, is the wrong insulin. You need something more like Protophane or Act Rapid at lunchtime that will help. Another very important thing is to think about when people give their insulin, and the mismatch can be particularly with the bolus insulin. When you have a pattern like this that you can see in this graph, where the blood glucose levels that you can see are going up and down like mountains, what this shows to me is that this person is giving their insulin after they've eaten. So what happens is they have their breakfast. Oh, I forgot, I haven't had my insulin. I better go and give my Novo Rapid or my Humalog or my Fiasp. And what happens is you have this steep rise. Whenever you have a rise in blood glucose levels greater than 45 degrees, it's usually because the insulin hasn't been given. And it's a really important thing to talk to people about, trying to get strategies to inject before they eat, at least 5, 10, 15 minutes before they eat. So this pattern is very clearly bolus insulin after meals. Other medications that can cause hyperglycemia. This is a lady who was 79 years old, type 2 diabetes for 12 years. A1C was always drifting between 7 and 8. You know, and that's pretty good for a woman who's 79 years old. She was on oral hypoglycemic agents and they were fine. She came to see us at the clinic and her A1C was 13%. And so, of course, we needed to start some insulin therapy. But there was no real improvement in her glucose levels. And we considered pancreatic cancer, because this is typical of what might happen in somebody like this. The investigations for pancreatic cancer proved to be negative. What transpired was that this woman's husband had died several months before, and she had been put on the antidepressant mirtazapine. And the antidepressant mirtazapine or the AAA agents markedly increased blood glucose levels, markedly. Now, not in everyone. Interestingly, we do see quite a few people on mirtazapine and their blood glucose levels remain okay, but it is a cause of increased blood glucose. And so if you have got somebody on mirtazapine, look at their blood glucoses as maybe a reason why the A1C has gone up, and if at all possible, to move it to an antidepressant or a AAA that doesn't cause such problems. That would be good. And what happened in this lady was that she was switched to sertraline, and in a few months, the blood glucose levels improved and her A1C went down to 6.8. And that was without changing her diabetes medications. That was simply converting the mirtazapine to sertraline. So other medications that can cause blood glucose levels to go up. This is a patient of mine with type 1 diabetes who's on a pump and doing all those blood glucose levels. And she came to me and said, "Oh, Margaret, I've started on an oral contraceptive pill." And then she said, "And I've noticed that my blood glucose levels have really elevated." And this is what can happen. So you can see that her blood glucose levels previously were good and reasonably in target. And then when she started on the pill, they went haywire. And so it's important, again, that's a question you need to ask in somebody who may be young enough to go on an oral contraceptive, need to go on an oral contraceptive. Have you started any new medications lately? So M, continuing the theme of M for medications that aren't diabetes related or aren't diabetes medications. This is a case study of Mr. 89-year-old MG. He was on amiodarone for cardiac arrhythmias. And you can see that his TSH is so low, T3, T4 elevated. He had no thyroid history, but what he developed was amiodarone-induced thyrotoxicosis. And this affects about 14 to 18% of people who've been on it long term and has a direct effect. The iodine has a direct effect on the thyroid, and it's a long half-life of 50 to 100 days, and it remains in stores up to 9 months after discontinuation. So this is a really tricky thing to try and manage if somebody gets amiodarone-induced thyrotoxicosis. And this old man was very thin and frail. He was so thyrotoxic. He'd had a huge weight loss. His A1C was 10%, and we were trying to manage him as we were trying to manage his thyrotoxicosis over time. We also had to try and manage his A1C, which was elevated because of the thyrotoxicosis. And his dear wife, who was trying to look after him as best she could, said to us, "I'm watching his food really carefully, and if his blood glucose levels have been elevated, I don't let him eat." Now, we do not manage elderly people by reducing their food. If we have to improve blood glucose levels, then we do it with medications. Because if you stop the food and cause weight loss in people, as you well know, it's not fat that they'll lose, it's muscle. And anyway, this man was emaciated and he needed food. And I said to her, "Let him eat what he wants." And she was horrified. She said, "Really?" And he looked up at me and he said, "Even ice cream?" And I said, "Yes, absolutely. You can have ice cream and we'll build you up with protein supplements and we'll chase you with some diabetes medications to try and keep your blood glucose levels down." So just in summary, we don't ask people to reduce their food if they're old and frail and thin. So what about something else? So you've got to think of something like LADA. What is LADA? Well, it's latent autoimmune diabetes in adults, and it's sort of like type 1 diabetes that occurs in adults. They're GAD positive. They're often older than the typical age for developing type 1 diabetes, although you can develop type 1 diabetes up to 90 years of age. It's equal between males and females. It's not age related, but what happens is they often come in and because of their age, you know, they might be in their 50s or 60s, you think, oh, this person has type 2 diabetes, and you start them on some medication, and they do quite well for a while, but then after about 6 or 12 months, they're needing more and more and more medication. And then you realise after a while that, in fact, this person's not doing well on the medication. They've reassured you that they're taking the medications as you prescribed, and they need insulin. So this is the typical, and then when you look back at them, you think, oh yes, actually they don't look like a typical type 2 person. They're fairly slim, they're very active. So anybody who comes in to see you, you think you diagnose them with type 2, they don't do well in those first few months or 12 months or even maybe 18 months, and you quickly need to move them to insulin. Think about whether it's LADA, because if it's LADA, they need basal bolus insulin. They're type 1. Is it something else? You know, is it Cushing syndrome? We don't see that very often, but when you do see it, it's marked, and that's again something that will push up the blood glucose levels. So just be aware of the florid face, the high blood glucose levels, the high blood pressure, maybe the hump, the stria that's very defined across the abdomen, and just keep in the back of your mind that these high blood glucose levels may be due to this. Or, continuing with something else, this is a patient of mine who's a 69-year-old farmer. He'd had type 2 diabetes for 10 years, spent 3 weeks working on the farm, and then came into town for 3 weeks. And so had a tablet, he was on tablets and insulin, and we had a treatment regimen for each setting, and was always well controlled. So the 3 weeks on the farm had much less medication because of the activity. 3 weeks in town having a rest, more medication. Went really well. And then the wheels fell off, and he started requiring much more insulin. A1C went up to 11% from about 7%. And then after some investigations, it turned out that this person had pancreas cancer. So again, it's a red flag. If somebody's been doing well for quite a long time, and you've gone through all the other, the A and the I and the M, and none of that is the cause of the high blood glucose level, you need to think about pancreas cancer, because we certainly do see a reasonable amount of it now in our populations. So this is another farmer who is 61. He's got type 1 diabetes and had it for about 32 years. Doesn't really have any significant complications. His recent A1C was 10%, and his weight was 86 kilos. And he's a fellow who is very set in his ways. He, you know, when he's with his A1C going up to 10%, I couldn't work out what was going on. I'd ask him about his food. You know, he didn't carbohydrate count, but he ate the same sort of breakfast, the same sort of lunch, the same sort of dinner, had fixed doses. His daily activity, he'd moved to Sydney, he became a dog walker, he monitored his blood glucoses regularly. It wasn't anxiety, it wasn't stress, nothing ever ruffled this man. And I just couldn't get to the bottom of it. And he was on Novo Rapid and Lantus, and a total daily dose of 108 units, which is a lot of insulin for somebody with type 1 diabetes, because people with type 1 diabetes usually need about 0.5 to 0.6 of a kilo units per kilo. And he was on nearly double that. So there was something not quite right. And I could see these blood glucose levels in his book were all over the place. And I said to him, do you ever give corrections? Are you giving extra doses? You know, I just couldn't understand why he required so much insulin and his control was still poor with his type 1 diabetes. And this is what his download of his meter looked like. You can see blood glucose levels up and down, but generally very high, reflecting the 10% A1C. And then I asked him to lift his shirt so I could check his injection sites. And this is not fat. This is 32 years of injecting into the same spot. And so this is lipohypertrophy. So what happens is the insulin causes this growth of fat under the skin, and these lumps become very hard. And as you can imagine, if you keep injecting into them, the insulin's not absorbed in an efficient and effective or systematic way. And so if you inject sometimes into those lumps and sometimes into a higher part that doesn't have the lumps, you're going to get the erratic sugars that we saw on that slide before. So what I said to him was, I want you to completely stop injecting into your abdomen. I want you to use your legs only. And then I put on a flash monitor to see what happened. And you can see that he was having hypos. And so I had to reduce his insulin. And he went down and down and down in his insulin dose, as you can see. And this was what it was when he was injecting into the lipohypertrophy. And these were his blood glucose levels when he started injecting into his legs. Amazing, isn't it? So all the thinking about what else was going on, we need to make sure that we just do simple, practical, clinical things like regularly checking people's injection sites, teaching them about not injecting into the same spot. And if you do find lipohypertrophy, ask them to move the site or use their legs. And his A1C went from 10% to 6.4%. And the only thing that changed was the injection site and then the need for me to have to reduce his insulin doses as the insulin was being better absorbed. So the final slide is this patient who is 72 years old. She's had type 1 diabetes for 21 years. A1C was always in the 7% range. I've been seeing her for a few years. A1C went up to 9%. And again, I couldn't work it out. So I applied the A.I.M.S acronym, which is what I do when I see people where the A1C is unexpectedly elevated. And I thought about A, and the big thing for her was that she was starting to dement. And as it's transpired, she's now been moved into a nursing home. I thought about inflammation and infection, and she had undergone some recent dental work at the Sydney Dental Hospital. I thought about M, and indeed she'd had a psychotic episode and been admitted to Manly Hospital for several months previously, and she'd been started on an atypical antipsychotic agent. And S, she lives alone, or lived alone, and she was isolated. So she had a whole lot of reasons why her blood glucose levels had gone up and her self-management skills had gone down. So finally, when you go to work tomorrow and you see somebody with diabetes and their blood glucose levels are elevated, please don't just automatically try and add more medications, increase their insulin doses, add more insulin. Think about the A.I.M.S acronym and think about what are some of the other causes of hyperglycemia that I need to think about. So in summary, the A.I.M.S acronym is A for adherence, and that refers to food, exercise, diabetes medicines, and attendance at your clinic. I is for infection or inflammation. Has the person developed a recent infection? M is for medications that aren't diabetes medications, but the steroids or the antidepressant mirtazapine or the AAAs or something else that may have caused those blood glucose levels to go up. And S is for something else, pancreas cancer, LADA, other syndromes that may cause it, or something as simple as lipohypertrophy. So that brings me to the end of my presentation, and I thank you very much for listening, and I hope that's been a practical and helpful guide so that when you go off to work tomorrow, I want you to practice the A.I.M.S and see how we go. Thank you very much.
Thank you, Margaret. That was wonderful. We do have some time for questions and answers. So if anyone has any questions they'd like to put into the question pane, we have Dr. Ramu Nachapan, who's a CPD advisor for the Far West region, who will be facilitating the questions. And we have Margaret and Professor Stephen Twigg, who will be answering those questions as they come through. And while we're waiting for some questions, once we finish the question and answer session, I will just put up the last slide for you, which does have a QR code. If you are able to scan that with your smartphones and just complete the SurveyMonkey link that takes you to for the evaluation. That'd be great. If you don't do that, there will be a link to the survey emailed to you about an hour after this presentation.
Thank you, Natalie. Thank you, Professor McGill, and I welcome Professor Twigg for joining us in this panel discussion. I realise in 50 minutes, Professor McGill has produced quite a turbocharged information session, which those of us in Broken Hill don't often have access to, so we're very grateful for your time and your energy. And very briefly, the points that Professor McGill mentioned: diet, exercise, medication compliance, practical approaches to patient care, clinical cases, and over-medicating. Words of pearls of wisdom, which I'm sure the 40 attendees today on the webinar, like myself, I'm extremely grateful for. So I might start off with some of the questions, and Natalie, thank you. Okay. So I've got Anne Balcom, who has asked, what is the mechanism for OCP increasing BSL? I assume that you're talking about the contraceptive pill, Anne.
Yeah. Steve, do you want to answer that one?
Yes, certainly, Marg. Yes. Hello, everyone, and Dr. Rami Natrapan, thank you for the welcome. Yes, I think the current belief is that it's the estrogen itself, particularly in the higher dose oral contraceptive, probably working through insulin resistance, that in some women can be prone to worsen glucose. And there's quite marked variability in it, consistent with Marg's nice presentation about the effects of medicine across the board. I should comment that as far as contraception goes, for women with diabetes, that there is an increasing emphasis on IUD and local hormonal release IUDs, rather than systemic approaches such as the oral contraceptive, because there is concern there might also be other related issues. Could even be that it's not necessarily cardioprotective, but there might be other concerns. So I think you might argue that the lower dose oral contraceptive and sex hormone therapy for postmenopausal women these days, it's less prone to cause this problem, but we still see it. And Marg gave a very nice example there of where it was highly reproducible in that woman with type 1 diabetes, the hyperglycemia. So, I mean, that's a simplistic answer, but that's our current understanding as to the mechanism.
Thank you, Professor Twigg. Did you want to add to that, Margaret?
No, that's fine with Steve. Yeah.
Okay. So while we're waiting for other questions, I was just going to make a comment. We've got very limited access to specialist services in Broken Hill, as I'm sure both of you are aware of. Do you think we need to always access specialist services for our diabetic patients? Or do you believe that we basically apply the best approach that we are aware of and have access to while we wait for opportunities to present, such as tonight's presentation?
Look, it's impossible for every person with diabetes in Australia to see a specialist, and it's not necessary. Primary care physicians and nurses do a brilliant job, and it's just about all of us working together as a team, and you having access to specialists that you can ring if you've got an issue that you want to discuss. But in my mind, the great majority of people with type 2 diabetes should be managed with primary care.
Thank you, Margaret. Vivian Prestige has also got a comment. She said she loves the...
Sorry, I might just comment a little further on that. Clearly, there's certain subgroups, type 1 diabetes, for example, complex type 2, where we can help. Marg and I with the team have been coming to Marymount now for a bit over 7 years, so we've gone past the 7-year itch. But I am aware as well that North Shore Hospital, that they do provide support. We come from RPA Hospital. do provide support, I think, for Broken Hill in a slightly different regimen and approach. And by all means, you know, we're readily approachable to help out. So utilise your specialist services where you think you need them. But keep in mind, primary care doctors, they often understand their patients much better than our scenarios, even though we do our best to develop the rapport. And then there's issues that you have access to services through EPC processes, and particularly psychologists, that we can't directly provide that type of referral. So as Mark says, you know, it's highly complementary in terms of general practice approaches. And you call us in when you need us, and you know, whichever service, whether it's RPA or North Shore, will be there to help. Thanks.
Thank you, Stephen. And I think tonight's presentation, if I can sort of encapsulate it, I think it's all about partnership and a multidisciplinary approach. And everyone's got a contribution to make. As the 40 attendees shows, the people from across the health scenario who've attended tonight. So it's about a team care for each of our patients. It's not my patient or your patient, but it's our patient. And we're all there in a partnership, aren't we, to try and help them. So I've got a comment here from Vivian Prestige that she loves the acronym, saying that it'll be on her computer as a prompt tomorrow. This is the A.I.M.S, I think she's talking about. So thank you very much for that, Margaret. I think that's extremely valuable. The next issue that Anne Balcom has again asked is, can you tell us more about Libra flash monitoring, cost, etc.?
Okay, so the Abbott company has developed a system of monitoring glucose levels, and it's just a little disc that has a little fibre in it, and it attaches to the arm, and it measures interstitial glucose. So it's not blood glucose, it's interstitial glucose. And in the current format, it's going to change when better additions come along, but in the current format, you either with a reader or with your phone, it has to be a certain level of phone, you scan this little disc on your wrist, on your arm, and it will give you a printout, a reading continuously, as long as you do it at least every 8 hours. And it's a fantastic way of looking at what's happening to glucose levels. It's a fantastic education tool for the person with diabetes, because they can see the impact of what food and exercise and medicines or not taking medicines has on their glucose. It's also fantastic for health professionals because we're getting so much more data that we can read and make sensible adjustments to treatment according to good data.
And Rami, I'd like to add to that brief. Oh, Marg might want to finish her thought. Yep.
No, I was just saying it's available for people with a healthcare card with type 1 diabetes, and they get that through the NDSS. Otherwise, you pay about $90, and it lasts for 14 days. Well, as long as sometimes it falls off, but it's supposed to last for about 14 days.
Rami, I agree with everything Marg said, of course, and there's the other issue in people for TGA approval. It's really for people on insulin therapy in Australia, so type 1 or type 2 diabetes on insulin, because in particular, that's where it can be highly useful and it's evidence-based in terms of minimising hypoglycemia. People can flash, they can do it, 10, 20 times a day, look at the trends in glucose, minimise the hypo risk. And also, in particular, if they're frequently dosing, they can even decide if they like to use the profiles to help them deliver their insulin at appropriate dosings. So $92.50 every 2 weeks. The really good thing is that a person can set up for that and they can get 2 weeks of a profile, and there aren't major upfront charges. And then Margaret and I often find that if they don't have the concession card, then they do need to pay for it. They can order it directly, and then sometimes they look at a 2-week profile and give a lot of information and help in adjusting therapy. So I should flag that I'm on a national advisory board, and I just had to give a talk to the College of GPs about this earlier this evening, and Marg also provides some support for Abbott diabetes care. But I think, as per anything, what we're telling you is what we believe and what we've observed, and people generally love it, as Marg said. Great device to help in self-care.
Excellent. Thank you, Stephen. There's a comment from Ajanta saying that thanks, Dr. Margaret, for the great presentation with very practical points which we can use on a daily basis in our practice. I think Ajanta speaks for everyone who's attended tonight on this webinar. The other issue that Anne has raised is that Orange Hospital does not have an endocrinologist for the last 2 years. Any suggestions?
It's tricky, isn't it? I think, yeah, really hard.
Yeah.
We need to come and see.
Steve,
Yeah, my only comment would be, I hope the LHD can work through that, Rami. It's so important, isn't it, to have access to, as you say, team-based support. I'm aware there are endocrinologists within Orange, and so I would hope that there would be a possibility of negotiated outcome. Diabetes is so common, and it's everyone's business as well. And as Marg was saying, so common in the elderly, and geriatricians, general physicians, they have an important role to play as well. So hopefully we will look further for state-based solutions. I would personally hope that there would be solutions to this particular issue right across the state. We're realising it in high-risk foot services. We now have a specialist high-risk foot service in every LHD in the state. And I would hope that other aspects could be more, if you like, better scheduled across the state. But at the moment, yeah, that's the way it is. And let's hope there's a local solution.
Yes, thank you, Steve. And certainly in Broken Hill, we haven't had an endocrinologist for many years. And certainly as far as access is concerned, such as the evidence by this webinar tonight with 40 attendees, we can do more, I think, with the technological developments and create more links and networks. For example, the eminent presenters tonight, both Margaret and Stephen, who've published books and journals and written chapters in books. We don't necessarily have access to clinicians of your caliber, but the fact that we can actually access your knowledge and perhaps run cases past you for our own improvement means that we better manage our patients in Broken Hill and other parts of isolated Australia. Do you have any comments on that?
Well, Steve and I would be very happy to be involved in some case discussions and things like that. Wouldn't we, Steve?
Oh, look, absolutely. And I should have said about Orange as well, I think there is an attempt at solutions for ambulatory care out of the hospital setting as well, Rami. But look, at the end of the day, absolutely, as Margaret said, we're very happy to help with particularly the educational aspects. And sometimes, as you're pointing out, Rami, with the telehealth, sometimes there's particular patient cases that in an anonymous way can be presented or discussed. But we learned from the clinical cases you've seen here that the A.I.M.S abbreviation or acronym, it came from our experience in managing patients and patient need. And that's why it's so readily applicable to the very nice case examples that Marg has given, because we find it's highly practical. We ourselves use it every day, and it's come from patient needs. So that's where we need to focus, of course.
Sure. How are we going for time? Natalie, can we keep going with some more questions, or do we need to wrap up? Or
We've got a few minutes, 4 minutes left.
Okay, sure.
If we have any more questions that participants have.
Okay, if you can just forward that on to me. And while I've got a minute, I'm very grateful for the PHN role in bringing this webinar together. Katie Pryor, Natalie Welsh from Broken Hill, and I think these are some of the best presentations we've had. And the COVID climate has perhaps improved our ability to learn and be all present, even though we're not physically, we're virtually present. So that's really... I have to say,
right, the technology is going to kill me.
Well,
everything I have to give seems to have a different platform.
Yeah, that's true. Well, that's one of the issues, isn't it? It's like all the different brand names for a generic medication, which confuses the patient, confuses the clinician, and in fact confuses the pharmacist.
Yes.
So I thought I'd ask you a question about that. What do? Do we say stick to the same brand and don't change brands? Is that something we should probably push our patients to do, Margaret?
I think we have to think up practical ways of coping with it, because I know that it's not uncommon for our people to come on 2 sulfonylurea medications with different names. Yeah, so try and stick to the same brand.
Yeah, my comment, Rami, is I thought I was pretty good with these brands. They're beyond me in terms of the multiple trade names. And the mirtazapine example was someone was on Axon or Axil or something or other, and finally it's when we went back through the medicines again, and then we realised, you know, what is this medicine? Well, that's actually a pine or a pine, you know, and sure, it was lower dose and for depression and not the bigger doses used for psychotic disorder. But the point you make is so important. We need to know our medicines, and really we'd like to ensure that with each medicine we know the generic. I think that's the only way to manage. We're not going to be able to remove the trade names, and as you say, we might ourselves prescribe a more limited series, but the pharmacists have a big say in this, of course, as to what trade names are ultimately dispensed for the patient. So, yeah, big challenge, isn't it?
Yeah, certainly, and it continues to be. And I think for the medical students and the young doctors in training who are part of this webinar, yes, it's a whole minefield out there, and try and keep it simple, I suppose. I'm sure the experts agree with me, and stick to medications we're aware of, stick to names that we're familiar with.
It was interesting today in our clinical meeting with the nurses, I couldn't remember Q-turn, the medication Q-turn, and I thought, how am I going to remember this? Anyway, I realised that it's dapagliflozin and linagliptin. That's it. That's DL, and I'm thinking driver's license DL, Q-turn, do a U-turn. So now I've got it in my head. I can remember now forever. But I had to do that association to try and remember it, because there are dozens of medication names to try and remember, and they've all got silly names.
Stephen, any suggestions on minimizing the multiple lists of medicines that we use in managing diabetic patients?
Well, I think as you said, Rami, we do need to try and probably limit the scope ourselves. But again, you know, that's usurped in dispensing, even if we tick that they can't change the medicine or the trade name. And so the pharmacists, I think at a national level, it would be very helpful. And we are helpful with, it is helpful with the electronic systems that we use, Medical Director, etc. They do typically have the generic name there, and that's often what will help. It depends, obviously, how it's set up. But I was just looking for that mirtazapine when it was AXIT, A-X-I-T, and no wonder I didn't know what it was. So, yeah, I think again, we'll need to always ensure that we know what the generic drug is, and we won't have full control over the trades.
Thanks, Stephen. One final question. I can see we're right on the last minute of the presentation from Yen Fan. Mark, are there specific triple A's to avoid completely in patients with poorly controlled BGLs?
Yeah, it tends to be the medications with the PHNs. Steve, do you want to add to that?
I think you've said it, Marg, and we were just saying there is a diversity of them. But there are, in the antidepressant field, there are even some medicines that can be insulin sensitizing. So changing the patient to sertraline, a common trade name there would be Zoloft, I think. You know, that's a serotonin reuptake inhibitor class, and that will certainly not cause hyperglycemia and may even be a bit insulin sensitizing. But we have to follow the, you know, if the psychiatrist recommends for antipsychotic reasons that certain medicine is needed, then we have to follow from the diabetes point of view. It's when, however, patients are put on those medicines and it's not appreciated by probably the broader team as to what challenges they can cause. So I'd say those entire classes, yeah, any of those medicines can actually exacerbate hyperglycemia in patients. And so, but we do have some alternatives.
Sure. Excellent. Thanks very much. Once again, Professor Margaret McGill and Professor Stephen Twigg for that extremely informative hour of diabetes education, and we look forward to more from both of you, hopefully in the near future.
Okay, thank you very much. Thank you, everybody, for giving up your Thursday evening.
Good night.
Thank
Bye-bye.
you. And if everyone can complete the evaluation online, that would be great.
Excellent. Thank you all again. Thanks,
Thank you.
Natalie.
Good night.
Thank you, Rami.
Bye.
Well done, Prof.
Thank you.